All right, we'll probably spend like the next 2 hours now on cardiovascular. We'll break it up so you don't go, Okay? I'm going to leave this slide up for a while. I don't think it's in your notes. So I'm going to leave that slide up for quite some time while you guys copy these things down. Okay? When we talk about cardiovascular problems, we always have to get a good history and physical, right? Right. Okay. Remember, in particular, children don't present in heart failure like adults do, particularly infants. Okay? So, infants aren't going to be like, how far can you crawl before you get tired? All right? Or how many pillows do you sleep with? They shouldn't be sleeping on any pillows. So that infants will not have the same signs and symptoms of heart failure that adults will have, or even older children. Okay? So the age is very important when you're reading the question and you're looking at what's going on to help you determine if they have congestive heart failure or not. Infants in possible heart failure will have problems with difficulty feeding. They get tired easy, especially while they feed, not because of crawling, but from feeding. They can sweat while feeding, and these are things that parents will tell you time and time again with each different case. They will also have tachypnea. So those are kind of subtle signs, but they make you suspicious in addition to your physical exam. Older children will have shortness of breath. Older children can have dyspnea on exertion. Orthopnea, edema, nocturnal dyspnea are uncommon in children. So it's not the same as in an adult. The physical exam. Again, you have from your resuscitation chapter, you have your normal heart rate. So you need to know normal heart rates for ages because they will have tachypnea if they're in heart failure. Tachycardia. So you need to know normal heart and normal respiratory rates for their ages. Height and weight are always helpful. If you're reading a test question and they start talking to you about something and you're thinking it's cardiac, look for information about the height and the weight and their percentiles. Because children with severe congenital heart disease many times will be small. Okay? They don't fit into the normal growth cycle because they may be short and light. They may have failure to thrive because they're chronically ill because of their heart failure. So you look at that. That could be useful information in a question. On exam, always, always, always palpate upper and lower extremity pulses. And you should get upper and lower extremity blood pressures. Because by getting the pulses, if you have a delay in the pulses, that makes you suspicious for coarctation. Right. Exam may be helpful by demonstrating RALs on auscultation. RALs are indicative of pulmonary edema and left-sided failure, whereas hepatomegaly on physical exam is indicative of right-sided heart failure. And you can have cyanosis and clubbing with congenital heart disease because you have persistent chronic hypoxia. And murmurs can be heard. And you need to know your murmur scale. Okay? And you have that in your notes. So a grade 1 murmur is very difficult to hear. I call it the cardiologist murmur. Okay? I hardly ever hear a grade 1. It has to be very quiet surrounding. The baby should not be crying. You have to listen hard. You might hear it. Okay? So that's a grade 1. A grade 2, I can hear it. If I can hear it, usually to me, that's a grade 2. Grade 3 is louder than a 2, but there is no thrill associated with it. So that thrills are for 4, 5, and 6. And if you want to know what a thrill is, it's like when you feel a cat purring, that you actually feel. That's a thrill. That vibration is a thrill. Okay? So a grade 4 is a loud enough murmur, and it has a thrill associated with it. A grade 5, again, is loud enough that it has a thrill, and if you take your stethoscope, and if this is the chest wall, and you just take your stethoscope and put it on its side, like that, then you will still hear it, still hear the murmur. And a grade 6 is such that obviously there's a thrill, and if you take your stethoscope and just put it just above the chest wall, you'll still hear the murmur. That's how loud it is. Okay? You need to know your classification of murmurs because they might ask you a question and you'll say, well, that murmur is not a bad murmur. It's an innocent murmur because it's not blah, blah, blah. So you need to know when they say a grade 1 or a grade 2 or a grade 5, that tells you you know what they're talking about. So that's why you need to know them. They're not going to ask you what's a grade 4 murmur, but you need to know that information to help answer the question. Okay? Diagnostic tests include chest x-rays, and we'll show you some. And you look at the size of the heart, you look at the lung fields. Is there increased flow to the lungs, decreased flow to the lungs? Look at the ribs for notching. Look at the position of the aorta and the pulmonary trunk. Are they switched? Well, that could be a transposition, right? The electrocardiogram is helpful. It tells you about right axis deviation, right ventricular hypertrophy, left ventricular hypertrophy, bundle branch block, things like that. MRI may be helpful. Is there a double aortic arch? Cardiac catheterization, angiography, and exercise testing, if it's appropriate. Most of the things that we're going to talk about when we talk about congenital heart disease, so we talk about ASDs, VSDs, the test of choice is going to be the echo. Okay, so you're going to be listening to the patient, you're going to examine the patient, you're going to look at the x-ray, but you're going to end up getting an echo. That's the best test to help determine what's wrong with this child if you suspect a congenital heart disease. Okay? All right. Can I take that down now? No? Oh, well, I'll put it up later. Okay, you're just starting. I'll put it up later. Remind me to leave it back up, okay? Because we need to... All right, so this is something you might see on physical exam. There's some cyanosis. See? Look at that difference there. And in dark-skinned individuals, where are you going to look for cyanosis? Mucous membrane. So you're going to look at the lips, you're going to look at the teeth, the gums, for cyanosis if they are dark-skinned individuals. Okay? Right here, what is this? Clubbing. That's not worth any chocolate. That was too easy. Okay? That's clubbing. What's this? This is not just, this is, pardon what? This is differential clubbing. This is a toe. This is a toe that's got clubbing, but the hand doesn't. Okay? So you can see this sometimes in very long-standing patent ductus arteriosus. So this is what's called differential clubbing. Only in the lower extremities is it happening. Okay. Whenever, we talked about the ears yesterday, or the very first day we talked about the ears, and we said the relationship of the ears, malformed ears, and genitourinary problems. If you see gross malformations of the upper extremities in particular, you should be thinking of associated cardiac defects. Okay, so if you're reading a question and all of a sudden they throw in something about the arms or an absent radius, like here, okay, you're sitting there going, why are they doing this? Now you should be thinking of congenital heart disease. So we have here an absent radius. We also have only 1, 2, 3, 4 fingers. This is a Holt or Ram, and that goes along with ASDs. Okay? So gross malformations of the upper extremities, you should be thinking of congenital heart disease. So as you're reading a question and they talk about it, you should be switching over to the congenital heart disease chapter. Okay, little embryology. And if you remember some embryology, remember the plumbing, it'll help you with the congenital heart diseases. And you have these, not as colorful. We gave you these in your handouts, okay? Where does oxygenation occur in utero? Down here at the placenta, okay? So oxygenated blood then comes through here, and actually the right side of the heart does a lot of pumping. The lungs, okay, the lungs are a high resistance, low flow field. you have some communication so that blood, because a lot of blood doesn't need to go to the lungs to get oxygenated, it's already oxygenated from the placenta, so blood needs to get over to the other side of the heart, not to the body. So how do we do this? We do this through the foramen ovale and through the ductus arteriosus. And that's how oxygenated blood can pretty much make its way out to the systemic circulation. Okay? All right, so let's see what happens. The cord is clamped, the baby takes a breath, placenta's gone, see, it's not there anymore, and now we're going to revert to our regular circulation, adult type circulation. Okay? So the foramen ovale starts to close and the ductus starts to close. Okay? The ductus closes physiologically, starts to close in response to oxygen tension, and it takes a couple of days for it to close. The foramen ovale takes a while to close too, so some of these connections can stay. Now with congenital heart disease, you can have some problems, and sometimes you need to remember that if you keep this open, or there has to be some other communication for the patient to be alive, depending on what the pathology is. So sometimes we can use this ductus to keep this ductus open to our advantage. And sometimes symptoms don't start to appear until the ductus starts to close. That's what we call ductal dependent lesions. When the ductus starts to close, then you start to see symptoms. Okay? So sometimes we'll use this to our advantage, but we also need to know that there have to be some other communications somewhere along the line so that the patient stays alive, or we have to make some communications. Okay? First, let's talk about innocent murmurs, because it is a common one. Again, remember I said they like to ask normal things sometimes when it comes to pediatrics, because it's not the same as in adults, and you sit there and you go, gosh, is this the right thing? Well, it's normal in a child. You don't need to do anything. A 5-year-old male is seen for routine physical examination. Parents voice no concerns. That's strange, huh? Weight and height are at the 75th percentile. That's important. Vital signs are normal. Physical exam is remarkable for a soft, musical, grade 2/6 murmur, best heard at the left lower sternal border. So there are some important things in this question. Number one, 5-year-old. That's important to know for the diagnosis. Number two, weight and height, 75th percentile. Obviously, this baby is not a failure to thrive, right? So it makes you less suspicious for something bad. The entire exam is normal except for this murmur. So this is probably an innocent murmur, also known as a functional murmur or a flow murmur. Some people call them insignificant murmurs. I like innocent. It's very reassuring when you tell the parent, your child has a murmur, but it's an innocent murmur. Oh, okay? It's very reassuring. All that happens here is that you're hearing the blood flow through a normal heart and vessels. You're just hearing it. That's all. There's no holes, there's no vegetations, nothing's wrong. Most innocent murmurs are heard between the ages of 3 and 7 years. That's why that age was important. This child is right smack dab in the middle at 5 years of age. Okay? More than 30% of children may have an innocent murmur heard at some time during their lives. That's reassuring too. Doesn't mean a thing then. They're usually just heard on routine physical exam, and they are sometimes heard when you have like increased cardiac output, such as like when you have a fever, your heart rate goes up a little bit, you might hear a flow murmur then, or you have an infection or you're nervous. Now, very rarely can you say always or never in medicine, correct? But an innocent murmur is never in diastole. Now that doesn't mean you can have pathologic murmurs that are in systole, okay? An innocent murmur is never diastolic, which means that if you ever hear a diastolic murmur, then it's pathologic. So innocent murmurs are always systolic. Innocent murmurs are not greater than a 2/6 in your classification system. Now, you can have pathologic murmurs that are 2s, but if you're hearing a 4 or a 5, that's not an innocent murmur. I don't care if it's just in systole. It's not innocent. So never in diastole, never greater than 2/6. Typically, it's a soft, what they call vibratory or musical murmur, and it's heard best at the left lower to mid-sternal border. What do you need to do for it? Nothing. You don't need to do any tests for it. You need to reassure the parents. What's your differential? You can have pulmonary flow murmurs, which is a form of an innocent murmur. They're a little bit higher pitched. They're blowing murmurs. They're heard in the earlier part of systole, and it'll be heard in a different spot. We said it was left lower sternal for innocent. This is going to be left parasternal with the patient laying down. Venous hums are heard in the neck or the anterior chest. It's heard, it's almost like a continuous. It's a systolic and diastolic murmur, but when you compress the jugular vein, you don't hear it anymore. Now, don't compress both jugulars at the same time, okay, on either side. Just one, and it kind of goes away. All right, so that's called a venous hum, and that's part of your differential diagnosis. Okay? All right. So now let's talk about congenital heart diseases. Occurs in about 0.5 to 0.8 per 100 live births. The lesions will occur early on at about 15 to 80 days of gestation. And the diagnosis is usually made early on in life. Over half of the patients will be diagnosed by the time they're 1 month of age, usually because they'll have symptoms or you'll hear the murmurs. It's important to know that murmurs may not be heard initially. Why? Let's go back to our embryology. Murmurs are only heard when there is flow through a defect. And the only time that you will have flow through a defect is if there's a difference in pressures. When babies are born, their pulmonary vascular resistance tends to be a little bit high still. So you may not hear a murmur. And then when the resistances drop, and it's enough of a change in the resistances or in the pressures, then you'll hear murmurs. So even though that ventricular septal defect is diagnosed at 3 or 4 months of age and the baby's had it since birth, it didn't develop it over the first 3 or 4 months, it wasn't heard until 3 or 4 months of age or 5 or 6 months of age till the pressures dropped enough that you could have flow across that defect. So you don't always hear the murmurs right away. 30% of patients with congenital heart disease have other anatomic abnormalities. We talked about the hand. Okay? We talked about patients with TE fistulas. You have to search for cardiac defects. Okay? So in children, we try to lump things together, and if there's one thing, we try to explain everything with one answer. So always look for other problems if you see some anatomic defects. And although we don't know the cause for congenital heart defects in most cases, we do know the cause in some cases, like congenital rubella or alcohol, fetal alcohol syndrome. Those are teratogens and they can affect the heart. We also know that certain syndromes, Noonan's, Downs, they course with congenital heart disease. Okay? We like to split them up. So we have a little table there that splits up the murmurs for you. And we have stenotic murmurs, and then we have murmurs that cause shunting. And the shunting is divided into right to left to right, or we have what's called mixing lesions. Under the stenotic lesions, we have aortic stenosis, pulmonic stenosis, and coarctation of the aorta. Right to left, some people will call them cyanotic lesions, right? And the left to right, people call acyanotic lesions. The mixing could be a cyanotic lesion depending on how much mixing there is. So when you think about cyanotic lesions, the best way to remember them is what we call the 5 T's and a P. Okay? 5 T's and a P for cyanotic. And the 5 T's are, should we use this thing? 5 T's? Let's use this thing, so we'll get them all down. So let's see. 1, 2, 3, 4, 5, P. Okay? So, let's hear one. Tricuspid atresia. Tetralogy of Fallot. Transposition. Truncus. Truncus arteriosus. And again, this is one of the tricky ones because it's a mixing lesion. So it depends on how much mixing you have if you're going to have cyanosis or not. You may have no cyanosis, but we lump it in there. What was this one? Total anomalous pulmonary venous return. Okay? That can be tricky too, because that sometimes with these you don't get cyanosis. We'll get to that in a minute. And the last one, pulmonic stenosis. Okay? So even though we talk about left to right, right to left, shunting, stenotic lesions, when people talk about cyanotic heart disease, think of the 5 T's and a P. And again, some of them are iffy. You can argue one way, but it just depends on how much mixing there is going on. And those are the big cyanotic heart diseases. Okay? We can throw in hypoplastic left heart and stuff like that too. But these are the biggies. All right? You got these? All right, let's do some of the acyanotic heart diseases. This is a ventricular septal defect. A 3-month-old child presents with poor feeding, poor weight gain, and tachypnea. Physical examination reveals a harsh, pansystolic 3/6 murmur at the left lower sternal border, and also there's hepatomegaly. Okay, so the murmur, harsh, pansystolic. So it means that you're not going to hear S1 and S2 very well. So it's basically a... That's what the murmur sounds like. Okay? And then you hear the diastolic component. Okay? VSD. VSD is the most common congenital heart defect. Okay? One of the reasons it's the most common is because it's going to be in association with other heart defects. So when we talk about tetralogy, there's a VSD. So VSDs as a whole make up, no pun intended, as a whole, they make up the most common heart defect, congenital heart defect. I just realized that. Okay, and here you see it. Okay, so here you have your right atrium, and this is also known as an acyanotic shunt or a left to right shunt, because normally what happens is blood from the systemic venous circulation comes into the right atrium, goes to the right ventricle, out the pulmonary trunk to get oxygenated. It comes back from the lungs via the pulmonary veins into the left atrium, plops into the left ventricle, and when the left ventricle beats, some blood goes out the aorta, but since there's a lesser resistance in the pulmonary vasculature, some blood will go across this way. There's less resistance in the right ventricle. There's a lower pressure. Some blood will go into the right ventricle, whereupon it goes back out to get reoxygenated. So it's a left to right or acyanotic shunt. See? That doesn't sound so bad. It can be bad depending on the size of the shunt. Okay? The manifestations, the presentation, depends on the size of the shunt. Okay? And again, in the beginning, you may not hear a lot of murmur because initially, if the pulmonary vascular resistance is high, you won't get a lot of shunting across that defect just yet. Okay? Large defects allow for a lot of left to right shunting. And that, again, depends on the differences in systemic and pulmonary vascular resistances. However, if you have persistently high flow from the left to the right side of the heart, and that means that you're going to have more flow to the lungs are going to do something. The pulmonary vasculature starts to hypertrophy a little bit to help limit the amount of flow to the lungs. They don't want too much flow, but they're getting extra flow. So over a long period of time, and the period of time depends again on the resistances, the difference in resistances, and on the size of the defect, you will start to get remodeling. And if it goes on long enough, you'll start to have pulmonary vascular resistance increase and pulmonary hypertension. And when it gets to a certain point where the pulmonary hypertension is high enough, you're going to start having instead of shunting from the left to the right, once the pulmonary vascular resistance is high, you're going to start having shunting from the right to the left, and now your acyanotic disease has become a cyanotic disease, and that's called Eisenmenger's complex. Okay? So that's why if it's a large defect, or when we get to the endocardial cushions, then you worry about this pulmonary hypertension, and it isn't such a good thing to have. Right? So you do need to fix them if they're large. Small defects are usually asymptomatic. The VSD murmur is usually the harsh holosystolic or pansystolic murmur that was described in the test question. You may or may not have a thrill. Large defects can lead to heart failure. So that will be manifested with dyspnea, poor feeding, poor weight gain, tachypnea, sweating while they feed, things like that. Chest X-ray for a VSD, if it's, will show a big heart, okay, an enlarged heart. Although, if it's a small defect, the heart won't be big. Echocardiogram will give you a left ventricular hypertrophy. Large defects will show biventricular hypertrophy on electrocardiogram because the right ventricle is doing more work too, because it's getting that overflow blood. The best test is the echocardiogram. The echo will show the defect or the defects. Sometimes it's multiple VSDs. They call Swiss cheese. Okay? Small defects will resolve on their own many times. Usually in 1 or 2 years, they will, as the heart grows and the muscle gets bigger, that defect will close up. Okay? You do need, as part of treatment, you need antibiotic prophylaxis for dental surgical procedures so that you don't get endocarditis. Medical management includes is managing the heart failure. So you put them on digitalis, you put them on diuretics, so you manage their heart failure, and the eventual treatment is going to be surgical closure of the defect. You put a patch. If it's small enough, you can close it, but if it's too big, you'll have to put a patch in there. And they tend to do very well. But the idea is trying to catch them at the right time. If they're not in heart failure, you want the child to either grow out of it or get big enough that you can do the surgery a lot easier because it's a bigger child. You worry about endocarditis, okay? So you need to treat with bacterial prophylaxis with antibiotics. And again, we can have pulmonary hypertension and eventually an Eisenmenger. Okay, so here's your VSD right there and right there. Okay, the ASD, the atrial septal defect, again, this is also an acyanotic heart disease, congenital heart disease. What happens here, there's your defect right there. So blood from the right atrium goes to the right ventricle, out to the lungs, comes back to the left ventricle, and some blood, well, most of the blood goes into the left ventricle, but some blood will scoot over to the right atrium because there's lower pressures, lower resistances, and it just kind of flows over there and goes back to the right ventricle and again to get oxygenated. Okay? So again, similar to the VSD, but it's a lower pressure. The atria, don't forget, are lower pressure chambers. ASDs occur anywhere along the atrial septum. The most common is the ostium secundum defect. Most patients are asymptomatic. You just hear a murmur. They don't present like this first one that we did. Okay? They can have some exercise intolerance as they get older. You will hear, and you have to know, this is like a classic murmur, a classic question. And again, this is a question I've seen in almost every level, from step 2 to pediatric boards. You always see something like this. The murmur is going to be a systolic murmur, okay? And the classic characteristic of it is a wide, fixed split of S2. You need to know that. You say, oh, ASD. Okay? Why? Normally, when you will have a splitting of S2 when you take, for example, a deep breath or regulated with breathing. Because when you're breathing, When you breathe in, you'll have a decrease in your intrathoracic pressure, and you'll have a little bit of extra blood is sucked from the systemic venous circulation into the right atrium, which means that you have a little bit extra blood going into the right ventricle, which means that you have a little bit extra blood going out the pulmonary trunk, which means it takes a little bit longer for the pulmonary valve to close. So you can have what's known as a physiologic splitting of S2. And you will hear that. That's the physiologic splitting of S2. Now, if you have an ASD, the reason that you're hearing a murmur in systole, okay, is that you have increased pulmonary blood flow. That's why you hear a systolic murmur. But why do you have the fixed split of S2? Because since you have this ASD, there's always more blood returning to the right atrium, more blood returning to the right ventricle, and more blood coming out the right ventricle, so that the pulmonary valves always close a little bit later, and that's why you have that wide fixed split of S2. So look for that when you're reading your question. That's the classic ASD murmur, systolic ejection murmur, wide fixed split of S2. Again, most patients don't have many problems. You can have some exercise intolerance. Diagnostic test. Well, the X-ray can show an enlarged right atrium and an enlarged right ventricle, depending on how big the shunt is. You can have right atrial enlargement and right ventricular conduction delay on your EKG, but the best test, echo. Okay? And you will fix this surgically. You can do this. Now they do have some devices, they call them these little buttons that you can slide in like through a femoral, put it into the heart, and put a button in through the defect, or you can actually do open heart surgery and patch closure. But either way, that's the definitive treatment, will be surgical closure of the defect. These do not close up on their own for the most part. Complications, generally you're asymptomatic until about the 3rd decade of life, when you can start to have some signs of failure. They are at risk for endocarditis, so you're not as at risk of endocarditis because it's not a high flow lesion, so you don't really need prophylaxis. However, you can have dysrhythmias, because if the defect is through some conduction pathway, you could have a dysrhythmia. You can also have valvular insufficiency. Rarely does heart failure occur. Again, that's a late finding. Most children are fixed by about 4 to 5 years of age if they have an ASD. They fix them at that age so that they don't have to miss school or anything. Before they start kindergarten, whatever, they're fixed. Okay. Patent ductus arteriosus, or a PDA. So the problem is up here. The ductus didn't close like it was supposed to. So blood, again, right atrium, right ventricle, goes pulmonary trunk to the lungs, back to the left atrium, to the left ventricle, out the aorta. In the old days, when you were a fetus, the blood would go from the pulmonary trunk to the aorta because that was the lower resistance. But now, in adult circulation, now that you're out in the real world, the lower resistance is the lungs, so blood from the aorta goes through the ductus back to the lungs. Okay? So again, it's a left to right shunt. Remember this location too when we talk about something else later. Remember the ductus. Okay? So a patent ductus arteriosus, the ductus doesn't close, and you're going to have blood from the aorta to the pulmonary trunk or pulmonary artery. It's more common in girls. It's also associated with rubella, congenital rubella. And it's very common in premature infants. Premature infants tend to respond better to medical management than term infants do with PDA. Okay? PDAs are sometimes useful for us. So if we have some lesions that we can bypass flow through the PDA, it can be very helpful to keep it open. So if there's a right ventricular outflow tract obstruction, then a PDA is helpful because there'll be some mixing of blood up here. If there's no blood coming out this way, you can have some mixing of blood here, which is very helpful, and we'll talk about that later. Small PDAs usually don't cause problems. Large PDAs can cause problems the same way that a VSD does. With a large PDA, you will have what's known as a wide pulse pressure. So normally, let's say, in infants, the pressures are lower, but instead of 120 over 80, you might have 120 over 60, 50, 40. Wide pulse pressure will be seen with patent ductus arteriosus. You can also, on physical exam, feel these bounding pulses in the preemie. You can feel these pulses on the palms and actually on the soles of the foot. Boom. You can feel those pulses. Sometimes there's a heave, and the typical murmur is what they call the machinery or the to and fro murmur. So it'll be heard in systole and diastole. It's the whole time. That's the typical murmur. Sometimes in infants you will just hear a systolic ejection murmur. So don't be fooled by that. Diagnostic test, a chest x-ray will show a prominent pulmonary artery because of the increased flow, increased pulmonary vascular markings because of the increased flow. Okay? The heart size may be normal, may be slightly enlarged. And what's the definitive test? The echocardiogram is the best test. You can see the PDA on your echocardiogram. Some of these PDAs can close spontaneously in premature babies. They also respond to indomethacin. So the best medication to give to close the PDA is indomethacin. In term babies, it doesn't work as well. So the best thing to do for term babies is surgical closure. They just ligate it. They do a little incision. It's not open heart surgery, so they do a little incision on the, by the ribs, come up there and just localize it and tie it off and cut it. Okay? So in preterm babies, you will respond better to indomethacin. In term babies, you will respond better to surgery. There's your PDA. See it? Obviously, it's not a good thing that the heart is being shown in a slide, but this is the PDA. Okay, endocardial cushion defects. This is really, even though it falls under a left to right, because endocardial cushion defects means that you have a common AV canal or an ASD and a VSD, it becomes cyanotic. Okay? It will become a cyanotic defect very quickly because of the increased flow to the lungs, and you can get the pulmonary hypertension in the Eisenmengers. So what happens here is that you're going to have, I think I have a picture of it. No, I don't. Okay. You're going to have both an atrial septal defect and a ventricular septal defect. Remember that the endocardial cushions are where the valves come from and the septum come from. And so you have a problem there, endocardial cushion defects. You will have an ASD, below it you will have a VSD, and very commonly you will have some mitral valve problems. Usually it's what's known as a cleft mitral valve. So that's an AV canal. It's much more common in Down syndrome. Very good. Okay? So patients with trisomy 21 are at higher risk. These patients, since there's a huge amount of flow to the lungs, these patients will go into heart failure very easily, very quickly. So they'll be infants and they will be in heart failure. 1, 2, 3 months of age, they'll be in heart failure already. Okay? And now you're caught between a rock and a hard place. These patients need to be managed medically until they get big enough for the surgery to be easier to do. But many times they can't get big enough because they're so sick from their heart failure that they're not gaining weight appropriately. So sometimes you kind of have to bite the bullet and go ahead and operate on them when they're less than optimal candidates. Just depends on how sick they are. Okay? So they will have heart failure early in infancy. They will have hepatomegaly, indicative of right-sided failure. They will have failure to thrive. On X-ray, you will see increased pulmonary blood flow, and they will have pulmonary hypertension, so they can develop Eisenmenger very quickly. They can have a thrill. The S2 will become widely split because of the increased pulmonary blood flow, and you can many times hear a diastolic murmur. Don't forget they have mitral valve insufficiency many times. The best test is the echo. Okay? Chest X-ray will show a big heart, The electrocardiogram will show left axis deviation, biventricular hypertrophy, right ventricular conduction delay because of the hypertrophy. But echo is the best test. And if you do color flow Doppler, you can see just blood shunting at both levels of the atrium and the ventricles. Surgery. First, you medically manage the failure until hopefully you can get them big enough for the surgery to be easier. But surgery is the definitive treatment of these patients. You patch both the ASD and the VSD, and you fix the cleft mitral valve if you can so they don't have mitral valve insufficiency. Okay? Technically, that's easy to do. The problem is post-operatively taking care of them, because now you have no pop-off valve. You have the right side of the heart that's not used to pumping against high pressures, and if they have enough of a pulmonary hypertension, the right side of the heart can fail all by itself, and you can run into problems. So post-operative care is very important in these patients. And here you see the mitral valve with the cleft. Okay, there's a defect there. Okay, there's a defect and a defect. And the valve through the defect, you can see it on this side. Yes? For screening, I mean, it is the best test. It's not a screening. You don't go straight to the echo. I mean, you hear a murmur, you don't echo them. You're going to get the X-ray, you're going to get the EKG and all that. That's the best test for the diagnosis is the echo. But you go through your channels, okay? And the best test is the echo. You're still going to get a chest X-ray. You're still going to get the EKG. Let's put it this way, while you're getting your echo machine up there. So it's the best test. Now, sometimes you can pick up some heart defects in utero. So, fetal echocardiography. But I would say it's not really a screening test, because screening means that you're going to do it on a large population trying to find a defect, whereas this is a test that you're doing for the diagnosis. Does that answer your question? Sort of? Okay. Okay, this is coarctation of the aorta. Right there. There's a little arrow even, okay? See how narrow it is coming out? Okay, very narrow. Coarctation of the aorta is a constriction of the aorta which can arise at any point, but most commonly, 98% of them, occur just below the origin of the left subclavian. Okay? So actually, this is where you're taking off. See these vessels taking off this way? There's your coarctation. They just open it all up for you. These are like intercostals coming out. That's why you have holes there. Right? So majority of them are at the origin of the left subclavian, and the majority of them have some kind of ductal type tissue. Very important. Okay? So let's give you a problem, a case, since you guys like to hear cases. A 9-day-old is brought to the emergency department because of difficulty feeding and having problems breathing. Physical exam reveals vital signs of blood pressure of 150 over 100 in the arm. The baby is tachypnic, retracting, and tachycardic with poor capillary refill. Now, the giveaway would be that the 150 over 100 in the arm for a 9-day-old. You think that's high? Yeah, that's pretty high. So your next test would be lower limb pressures. Very good. Don't go to the echo yet. Lower limb pressures. So in the lower extremities, 50 over 30. So what does this patient have until proven otherwise? Coarctation. Okay? So that's not just the case I just made up. That's a case that really happened to me. And this child was in heart failure, and nobody had bothered to take pressures in the lower extremities. So we got to the emergency department, to the room, ran in there, and I don't feel any pulses down here. Anybody take a blood pressure? No. Can you get one, please? Sure. And it was like 50 over 30. Got my diagnosis. Okay? So before you even echo this child, so I'll give that away. You don't need to echo them right away. What is your next step? No. Chest X-ray is already being done. Lower limb what? You already know it's lower limb pressures are low. What would be your next step in the management of this child? No, they're not. What's the next step in the management of this patient? Prostaglandin. Why? Keep the ductus open. I just told you it has ductal tissue in it. Okay? So this patient, you need to keep the ductus open so you can get some forward flow to the rest of the body. Okay? All right. So coarctation is more common in boys, but there is an increased incidence in Turner syndrome, which is associated with a bicuspid aortic valve and coarctation. Coarctation can be missed in a newborn. How come they didn't get this earlier? He's 9 days old. How come they didn't pick it up in the nursery? Because the ductus was still open. And it's when the ductus closes that you start having problems. And that's why you want to reopen that ductus at least until you can fix it. Okay? So patients can present with congestive heart failure, metabolic acidosis, and lower body hypoperfusion. Okay? There you go. Hypertension will be in the upper extremities, hypotension in the lower extremities, and you can also have differences in blood pressures in the right versus the left upper extremity. If you have that, then you know that it's probably around the left subclavian because of the blood flow being affected, and so you see that you have hypertension on the right and not on the left. You may hear a murmur. Chest X-ray, findings will depend on the age of the patient. Remember what we call rib notching. Okay? Those patients are basically patients that are a little bit older. The coarctation is not as dramatic, and so they have time to develop collateral circulation. And so here you have all this collateral circulation, and when you have collateral circulation, because of the coarctation, over here somewhere, okay, there it is. There's a coarctation. Your internal mammary arteries will then, or internal thoracics, will then supply blood flow down to the rest of the body, and out of the intercostals, they'll also be engorged, and they kind of erode away at the ribs, and that's why you have rib notching. Okay? However, that is something that takes time. So this 9-day-old is not going to have rib notching because he's not had time for this. So that implies a much milder coarctation. Okay? I remember when I was, a long time ago, one of the medical students told me about a patient that was diagnosed with coarctation at the VA. He was like 33 years old, had no risk factors, and he came in heart failure. When they took the x-ray, somebody picked up the rib notching, and they found out he had coarctation, which had previously never been diagnosed. Okay? So it must have been a milder type thing, and that's why you see rib notching. What else gives you rib notching? Pardon? A completely different disease. Doesn't have to do with the heart. Rickets now. What else? Von Recklinghausen's. Von Recklinghausen's, because the neurofibromas along the intercostal nerves will cause rib notching. This one's for me, right over here. Okay? Okay. Okay, diagnostic tests. Chest x-rays we talked about. Severe coarctation will reveal cardiac enlargement in the infant and increased pulmonary vascular markings. Older patients can have rib notching. EKG will show right ventricular hypertrophy in the infant. Okay? And left ventricular hypertrophy is seen later in childhood as you try to overcome that obstruction if it's a milder one. Okay? And the test of choice for the diagnosis is? Echo. Very good. Trainable. Okay, treatment. First of all, if it's a ductal dependent one, you start them on prostaglandin, and surgical correction is the actual thing that you do. Okay? And complications, patients with coarctation can develop hypertension. Why? Besides the hypertension up here. Why can they develop hypertension? Because the kidneys aren't seeing any blood, so they start producing, right. Very good. Okay? They can also have premature coronary artery disease, heart failure, encephalopathy, and intracranial hemorrhage because of the hypertension up there. Adults are at higher risk for endocarditis. Cyanotic heart diseases. And like I said, we're going to try to lump these together, but if there's mixing, it depends on the amount of mixing. The first one is tetralogy of Fallot. A 6-month-old infant is prone to episodes of restlessness, cyanosis, and gasping respirations. Symptoms resolve when he is placed in the knee-chest position. Physical exam reveals an underweight infant with a harsh holosystolic murmur. This next one's really important. A single heart sound. Okay? That's really important. Okay, so by definition, what is tetralogy of Fallot? Let's look at the picture. Okay? We got pulmonary stenosis right here. And really more so than the pulmonary valve, it's what we call infundibular stenosis. So it's this area just below the pulmonary valve that is stenotic or sometimes kind of reactive. It can spasm a little bit, and that's what can lead to these what we call TET spells. Okay? So we have pulmonary stenosis. We have an overriding aorta. So the aorta is a little bit shifted over this way, so it kind of sits over the VSD. And you have right ventricular hypertrophy. So 1, 2, 3, 4 tetralogy. What's the pentalogy? So ASD, if you throw in an ASD, then you have what's known as the pentalogy of Fallot, not as common. Okay? Symptoms, again, will depend on the size of the VSD and the degree of this obstruction, the right ventricular outflow tract obstruction or the infundibular, call it pulmonary stenosis. Remember that tetralogy of Fallot is the most common cyanotic congenital heart disease. Now, it may not present with cyanosis in the first 24 hours of life. If a heart disease presents with cyanosis in the first 24 hours of life, then you're going to think of transposition. Okay? But overall, as far as cyanotic heart diseases, tetralogy of Fallot is the most common. You can have what's known as a pink TET, or acyanotic tetralogy, if there is enough pulmonary blood flow, which means that there's not as much shunting or as much right ventricular outflow tract obstruction. And then you can have what's known as a pink TET, which is, if you're going to have it, that's a good one to have. Right? Most patients will present with cyanosis, delayed growth and development. They're chronically ill, they're in heart failure, they're hypoxic. They can have dyspnea, and they have what are known as paroxysmal hypercyanotic attacks, also known as hypoxic attacks or blue spells or TET spells. This happens when the patient has this little spasm there, and so you have increased right to left shunting, and that's what's happening in this question. This patient is having episodes of restlessness, cyanosis, and gasping because they're hypoxic, and that's known as the TET spell. It's relieved by putting the infant in the knee-chest position. In older children, they will relieve it by a process called squatting. So they will actually go like this and squat. Parents learn to put the knee up to the chest in the infant. What does that do? That increases your systemic vascular resistance. Because you're scrunching, it increases the systemic vascular resistance and decreases, since your systemic vascular resistance is higher now, it decreases the amount of shunting that occurs this way. And it helps. Okay, so that's one way of treating these TET spells, is to sedate the patient, give them oxygen, and try to increase their systemic vascular resistance. So the knee-chest position is really good. You will see clubbing because of the chronic hypoxia, and you will hear a loud, harsh systolic ejection murmur. Why is S2 single? Because of the pulmonic stenosis, this isn't closing, so all you're hearing is the aortic valve closing. So that's why there's a single sound to the S2. Diagnostic tests. Oops, here's some more fun. So here you see the clubbing. Okay. Let's see. interventricular septum. Well, there's going to be a hole there. Overriding aortic valve right here. Okay. This is the narrowed pulmonary outlet over here. Okay. All right. On chest X-ray, the classic tetralogy of Fallot will have what's known as the boot-shaped heart. See it? Looks like a ski boot or something. Who speaks French here? Anybody speak French? Corps and, how do you say boot? Sabot. Corps and sabot. Okay? So corps and sabot, boot-shaped heart. What else do you notice here? Look how black the lungs are. Why is that? Because of decreased pulmonary blood flow. So you're not seeing the fluid when you take the X-ray. It looks like it's overexposed. Okay? So the decreased pulmonary blood flow will show up as this black kind of lungs look. Okay? So that's what you can see on chest X-ray. The electrocardiogram shows right ventricular hypertrophy. It's part of the disease. And a right axis deviation. And the test of choice is the echo, which shows all the defects. Okay? Medical management of tetralogy of Fallot. If they have severe right-sided obstructive lesion, you may want to keep the ductus open for a little while. Okay? Surgical correction is the definitive treatment. Now, sometimes you can do like a BT shunts and stuff like that to get blood flow to the lungs. But surgical correction of all the defects is the definitive treatment. Blue spells are treated with beta blockade, sedation, oxygen, the knee-chest position, and try to avoid acidosis. Also, you try to maintain them properly hydrated, very important. And these patients, since they're chronically hypoxic, they tend to have very high hematocrit, so you don't want it to go too high. I remember a child that was 10 years old, and he was lucky to, usually if you have tetralogy of Fallot and it's uncorrected, you're dead by that age. This child had come over from Cuba to Miami, was a Jehovah's Witness, and they did not want surgery in Cuba. And they escaped, and they were in Miami, and they went to get their surgery because they heard of bloodless surgery. And he could barely walk from here to that table without getting tired. And he had huge, amazing amount of clubbing. And when he came out of surgery and out of the anesthesia, he would just sit there all day long and go like this and look at his fingers. They were still clubbed, but they weren't blue anymore. And he could just go like that, okay, after the correction. So surgical correction is the definitive treatment. With the surgical correction being done earlier at an appropriate age, then you don't have as many complications. But you have to worry about cerebral thrombosis because of the polycythemia, because of the chronic hypoxia. Okay? Usually that's in patients less than 2 years of age. Brain abscesses. There you see a nice little ring-enhancing lesion. That's a brain abscess in a patient with tetralogy of Fallot. Brain abscesses are not as common as thrombosis, but it is more common in patients older than 2 years of age. And of course, they're at high risk for bacterial endocarditis. Okay, next is transposition of the great arteries or of the great vessels. And this is where you just switch them over. So here's what happens. You have the right ventricle, blood from the systemic venous circulation comes into the right atrium, into the right ventricle, out the aorta, and if it goes out the aorta, where's it going to go? Back out to the body. Meanwhile, blood from the lungs goes into the left atrium, into the left ventricle, and out the pulmonary trunk. And where's that going to go? Back to the lungs. So you basically have two separate circulations. That's obviously incompatible with life. So, knowing your embryology, you know that there has to be some kind of communication for the blood to mix. And that's going to happen either through a ductus, an ASD, or a VSD. Those are the three spots where you can have some shunting, and that way you can have some mixing of the blood. So when this baby is born, and we said this is the most common cause of cyanosis, if it's a congenital heart disease, it's the most common cyanotic congenital heart disease to present with cyanosis in the first 24 hours of life. So what are you going to do for this patient as soon as you suspect it? Prostaglandin, because you don't know if they have an ASD, you don't know if they have a VSD, but by golly, you know they have a ductus, and so you can keep that open until you find out what else is going on. Okay? So that's a transposition. It's more common in infants of diabetic mothers and also in boys. So again, look for cyanosis in the first 24 hours of life and rapid onset of heart failure. You may or may not hear a murmur. Again, for X-rays, it's known as the egg on a string. Oh, there it is. It's known as the egg on a string because you don't have the normal one vessel going this way and another one going like that. You just have this, and it looks like an egg hanging on a string. So look for that as your X-ray finding, the egg on a string. The definitive test is echo. All right. Yeah, that's not worth any chocolate anymore, okay? And you keep them on prostaglandin until you figure out what's going on. Okay, pulmonary atresia. This is tricuspid atresia. Pulmonary atresia, the right ventricular blood will back up. It's a right ventricular outflow tract obstruction. So blood backs up from the ventricle, and where's it going to go? It's going to shunt across the foramen ovale, and therefore you get right to left shunting. You get a cyanotic heart disease. Okay? Usually occurs after 2 to 3 days when the ductus will close. You will also hear a single second heart sound. And the EKG will show tall spiked P waves, and there'll be right atrial enlargement and left ventricular hypertrophy. And the treatment is keep the ductus open, because it's a ductal dependent lesion, until definitive surgery. This is tricuspid atresia. Okay? Tricuspid atresia is basically a right-sided obstruction. It's not a right ventricular outflow tract obstruction, but it's higher up, and so it's basically a right atrial outflow tract obstruction. So blood, where's it going to go? If it can't get very well into the right ventricle, where's it going to go? Across the foramen ovale, okay? And from there, it becomes a cyanotic heart disease. So again, you need to keep the ductus open. You will hear a single second heart sound, and surgical correction is the way to go. What you do with tricuspid atresias, here you see a baby that has red up here, or cyanotic actually. He's cyanotic. Here is here's an atrial septal defect, so you can shunt across at that level, okay? And this one has a little bit of a VSD too in this particular case. But straight out and out tricuspid atresia is just you're going to shunt across the foramen ovale, and the treatment initially is what's known as a Glenn. The Glenn procedure, you're going to take the superior vena cava and you're going to hook it up to the pulmonary artery so that blood passively returns from the head and neck to the lungs. Okay? And doesn't go into the right side of the heart. Then when the baby is bigger, why do you do that? Because a significant amount of circulation returns from the head and neck, and so it can get oxygenated. As the child gets older and the circulation proportionally becomes less from the head and neck, the return, then you do the second step, which is the Fontan. The Fontan is the second step of you're going to take the inferior vena cava and hook it up to the pulmonary trunk, and basically you have passive return to the lungs. Okay? We'll get to that in a second. Total anomalous pulmonary venous return. This one is a tough one to understand at times. What happens with total anomalous pulmonary venous return is that the 4 pulmonary veins normally return to the left atrium with oxygenated blood. With total anomalous pulmonary venous return, one or all of the vessels will return to the systemic venous circulation. So basically you have oxygenated blood going back to the venous circulation, coming back to the heart, to the right side of the heart to go back to the lungs. So it sounds like it's a left to right shunt. The problem is that you're going to have these vessels, since they're going back a different way, they're going to take a very long, circuitous, tortuous route, one or all of them. And so they can kink off. And if they kink off, then blood backs up to the lungs, backs up even farther, and then you get right to left shunting and cyanosis. Okay? Does that seem plausible? Yes. Okay? So that's because of the circulation, since the vessels are going a different way, they can kink off, you get obstruction to blood flow, and all that blood basically backs up. And when it gets back to the heart, then it can back up and go right to left through a foramen ovale or something like that. So then you will have some cyanosis. So it's kind of like a mixing lesion, but you can have cyanosis depending on the amount of mixing. So mixed blood will reach the left atrium through an ASD or foramen ovale. The characteristic X-ray is what's known as the snowman or the figure 8. I don't have a slide for you, sorry. Okay, the snowman or figure 8 is the characteristic X-ray figure. How do you make the diagnosis, however? Echo. Echo. All right. This is a truncus. The truncus, basically, and there's different forms of truncus, but basically what happens is you have one common vessel coming out of the ventricles. So rather than having a pulmonary trunk and an aorta, they kind of come up together, and that's where the mixing can occur. And depending on the type of truncal defect, you can have too much mixing and you can have cyanosis. The treatment, again, is going to be, definitive treatment is going to be surgical correction. These patients can be cyanotic, and there's a high association of conotruncal defects and what syndrome? Hypocalcemic infant? DeGeorge. There you go. Okay? So a single vessel arises from the ventricles, and it supplies systemic, pulmonary, and coronary blood flow, and you always have a VSD. So you may not have cyanosis initially because of the high pulmonary vascular resistance, but as the resistance drops, blood flow will increase, and then you'll have increased pulmonary vascular resistance, and kind of like an Eisenmenger. Okay, so you will get cyanotic, and they can have a heart failure. And you correct surgically. And the last of the diseases is hypoplastic left heart. That's not it. That's not it. Okay? Hypoplastic left heart. And that is basically a lot of these a lot of different lesions that cause underdevelopment of the left side of the heart. Okay? So that's why they call it hypoplastic left heart. So there's underdevelopment of the left side of the heart, a small left heart. The right heart has to do most of the work. The right heart is not made to pump against high resistances, and so it'll fail. And you can have pulmonary venous hypertension. And so they will quickly, I mean, within a matter of a couple of hours, they can go into florid congestive heart failure, these newborns. And you can see the X-ray just getting worse and worse and worse. And again, you're going to make the diagnosis how? Echo. And the treatment is surgical correction. These patients do very poorly. Okay? All right. So let's finish up with a couple of myocardial diseases and rheumatic fever and stuff, and then we'll let you go. A 7-year-old girl presents to the office with a 3-week history of progressive dyspnea, malaise, and fatigue. She has recently recovered from a viral syndrome. Physical exam is remarkable for a holosystolic murmur and hepatomegaly. So this child is in congestive heart failure, right? She's got hepatomegaly. She's got a murmur now. She's tired. So this is myocarditis, an inflammation of the myocardium. And there's very different causes. In this particular case, what do you think happened to this girl? It's viral. She probably has Coxsackie virus or something. So this is probably a viral cause, given the fact that she just recovered from a viral syndrome. But there are other causes. Viral causes include adenovirus and Coxsackie virus, but diphtheria, rickettsia, fungal infections, and parasites can also cause myocarditis. And you can have connective tissue and granulomatous tissue diseases can also cause myocarditis. So it's not just a virus. Heart failure is the most common presentation. If you're lucky enough to get a history of a prior viral infection, great. Okay? It can have arrhythmias and actually sudden death, but not as common. Infants have a more acute and fulminant presentation. They don't handle it as well. And viral myocarditis is usually preceded by a viral infection. Fever, heart failure, respiratory distress, and cyanosis may all be present. ESR, for how do you diagnose this? Well, a SED rate may be helpful. It will be high, but a SED rate is nonspecific. So that's not your best test. That's not your first test. Okay? LDH may be high. Serum viral titers can be helpful only if they're elevated or positive. PCR is also good for viruses. Chest X-ray, nonspecific. It shows you a large heart, shows you that you're in heart failure. Electrocardiogram shows sinus tachycardia, maybe a reduced QRS complex and abnormal S and ST waves. Echo. Now we're getting a little bit better here. Echo shows poor ventricular function and a possible pericardial effusion. It can also eliminate congenital heart disease. You say, well, there's no vegetations, there's no ASD, no VSD, the valves are fine, it's not congenital heart disease, but the ventricles aren't functioning well. So the best test, I'm not saying it's the first test, okay, is an endomyocardial biopsy. Okay? That's the best test. Now, I'm not going to say that's the first test or the most common test, but that's the best test. And you're going to work your way through. You don't just go to the biopsy right away. You're going to do all these other tests first, because there's a significant risk in doing a biopsy, right? Okay, treatment includes manage the heart failure, manage the arrhythmias. If you have pericardial effusions that are significant enough, you probably need to tap them. You don't want to have a tamponade. Steroids are controversial, and if the patient is refractory to medical management, you need to have a heart transplant. Prognosis is pretty poor. Now, spontaneous regression resolution can occur. Sometimes it's these acute fulminant ones that actually do better. They get better on their own as opposed to the chronic one that's been going on for a while. Okay, this is endocardial fibroelastosis. It looks like an egg white, doesn't it? Okay, since we're getting close to dinner time, we have to relate everything to food. Egg on a string, you know, egg white. Okay, so that's endocardial fibroelastosis. It's characterized by a thickened, white, fibroelastic endocardium. That's why it's called endocardial fibroelastosis. That describes it very nicely. You can have primary or secondary EFE. And primary means that there's no predisposing valvular lesion. Secondary means that you have some predisposing valvular lesion. Okay, that means you have severe left-sided obstructive disease for secondary. With primary, you will have a dilated left ventricle, and secondary will have a contracted ventricular cavity. So there's a little bit different between one and the other. Usually these patients present with congestive heart failure. In infants, the signs of congested heart failure are going to be dyspnea, poor feeding, poor weight gain, sweating. We've talked about it several times already. The chest X-ray shows a big heart. The electrocardiogram shows a left ventricular enlargement and left ventricular strain. The echo, still the best, shows a poorly functioning ventricle. And again, medical management of the congestive heart failure, and if that fails, they need a heart. Okay, a couple more. Acute rheumatic fever. A 6-year-old girl complains of severe joint pains of her elbows and wrists. She has had fever for the past 4 days. Past history reveals a sore throat 1 month ago. Physical exam is remarkable for swollen, painful joints and a heart murmur. Lab tests show an elevated ESR and a high antistreptolysin O titer. Okay? You have to know your criteria. You have to know your Jones criteria. Okay? So rheumatic fever is caused by infection with group A beta hemolytic strep. So you will have a history of a prior pharyngitis. Skin infections with group A do not predispose you to rheumatic fevers, but the upper respiratory infections do. Okay, usually it's 1 to 3 weeks after having had the pharyngitis. This is why you don't need to treat bacterial or group A beta hemolytic strep pharyngitis right away. You can wait on that culture, that throat culture, to come back if your strep screen is negative. You can wait for the throat culture to come back because you have a few days still before the patient is at higher risk. Usually happens 1 week or more after having had this strep throat. And the Jones criteria are listed below. You have to know them because you'll be reading the test question and you'll sit there and go, okay, there's one. That's a minor. That's a major. No, that's not it. You have to do that. Okay? So, the major criteria are carditis, polyarthritis, erythema marginatum, that's what you see here. This is the rash. Okay? Chorea and subcutaneous nodules. Minor criteria are going to be fever, arthralgia, not arthritis, but arthralgia, an elevated acute phase reactant, meaning your SED rate or your C-reactive protein, prolonged PR interval on EKG, plus evidence of a preceding strep infection like a throat culture or increased ASO titers. Okay? And so there's a mnemonic for these criteria. Okay? The mnemonic for the Jones criteria is Jones. So the J stands for joints, the O looks like a heart, so that's carditis. The N is the nodules, the E is the erythema, and the S is Sydenham's chorea. Okay? Another mnemonic is access, ACCES, arthritis, chorea, carditis, erythema, and subcutaneous nodules. You have them in your notes. Okay? So, if you have 2 major criteria, stop, do not pass go, go directly to rheumatic fever. Okay? If you have 1 major and 2 minor plus preceding evidence of a preceding infection, then it's also. So it's a diagnosis of exclusion and by these criteria. So you don't have a particular test that you draw unless you're talking about ASOs and stuff. There is no one best test. You have to fulfill the criteria. Okay? Here's some more rash. You can see some nodules now, I think. Okay, there's a little nodule. This one is hard to see here. Are you ready? This is the mother of all nodules. Ooh. Okay? Subcutaneous nodules. The treatment is going to be management of acute rheumatic fever begins with treatment of the strep infection. So you start them on penicillin, and then they're going to need monthly penicillin till they're like 21. And after that, the adults see them. But certainly up to 21. Okay? Salicylates will help control the arthritis and also treat the carditis without failure. Steroids are used if you have carditis and heart failure. And heart failure is treated like you treat anybody with heart failure. Complications include valvular disease. You will get mitral valve insufficiency. Okay? And these are in order: mitral, aortic, tricuspid, and pulmonary valves. In that order. The mitral valve is the most commonly affected valve for rheumatic fever. Okay? Okay. I think that's enough rheumatic fever. Let's do a little endocarditis. A 6-year-old boy has had high intermittent fevers for 3 weeks, accompanied by chills. He has a past history of bicuspid aortic valves and recently had dental work. So that's a setup right there. You have a high outflow, left-sided lesion, and you had dental work. Okay? So that sets you up for endocarditis. Strep viridans is the most common cause of endocarditis. Some series, they'll talk about Staph aureus, particularly if there is no underlying heart disease. But if you have to pick, and the patient has an underlying heart disease, strep viridans, number 1. And strep viridans is more common after dental procedures. So this poor boy, it's strep viridans. Pseudomonas and Serratia are more commonly seen in intravenous drug abusers. And you can have fungal causes after open heart surgery. Endocarditis is most commonly seen after rheumatic fever, okay, or congenital heart disease. And again, surgical procedures can be an inciting cause. Higher risk occurs in patients with high velocity blood flow. So that means a patient with a VSD or a left-sided obstructive lesion like this bicuspid aortic valve. Fever, fever, fever is really important in these patients. They have very high fevers. They can have chills, arthralgia. They look sick, they feel sick. They can have new murmurs heard because of vegetations on the valves. They may have splenomegaly and petechia. If they have neurologic complications, it could be associated with Staph aureus. Skin manifestations usually are secondary to a vasculitis, and these include, right here, Osler's nodes. These are little tender erythematous areas on the fingers and toe pads, little nodules, Osler's nodes. They can have painless hemorrhagic lesions known as Janeway lesions, and I think it's these. I'm not too sure. Okay? These are hemorrhagic lesions too. These are splinter hemorrhages. Okay? These are all thromboembolic phenomena that occur with endocarditis. The diagnosis, blood culture. You're going to get a bug, okay? So blood culture is the way you make the diet, and you culture them. You may not get it today. They spike a fever, you do it again tomorrow. They spike a fever the next day, you do it again, and you keep culturing until you get something, because you're going to get something most of the time. That's the most important piece of the puzzle, okay? You can have increased white count, you can have an increased sed rate, but you got to get a bug, so you keep culturing that patient. Echo can reveal vegetations. And the treatment will be with antibiotics. You manage the heart failure, but you've got to treat this episode with antibiotics. Okay? All right. Last subject, hypertension. A 5-year-old girl is noted to have blood pressure above the 95th percentile on routine physical exam. The rest of the examination is unremarkable. Her blood pressure remains elevated on repeat measurements over the next few weeks. Past history is remarkable for a treated urinary tract infection 1 year ago. CBC is normal. UA is normal. BUN is 24, and creatinine is 1.8. Okay? This question has tons of information. First of all, 5 years of age. Okay? Hypertension in older children, like adolescents, is similar to hypertension in adults. The most common cause is essential or idiopathic. But if you see a 5-year-old with hypertension, you got to pay attention to it. You got to work it up. So that first sentence is a really important piece of information. Okay? Another piece of information that's important, her blood pressure remains elevated on repeat measurements over the next few weeks. So just because your blood pressure is high once doesn't mean you have hypertension. So you need to repeat the measurements. You need to use the right size cuff and things like that. Okay? So repeated blood pressure measurements that are high, that's hypertension. And a third piece of the puzzle here, she had a urinary tract infection a year ago. In younger children, the majority of hypertension will be renal related. I put it over here with the cardiology, but it's usually renal related. Okay? So, systemic hypertension is defined as a blood pressure above the 95th percentile for age, and there will be scales, they'll have to tell you that, on repeated measurements over a 6-week period. Hypertension can be primary, essential, or secondary. And primary, like we said, usually there's no underlying factors or causes. It can be related to hereditary factors or salt intake or diet or stress or obesity, things like that. And it's going to be more common in older children, so adolescents. secondary, you have to pay attention. And that's what they're generally going to ask you, is secondary hypertension, because they're going to try to confuse you. It's essential, just like in adults. No, it's not. Okay? Usually it's caused by renal disease, 75 to 80% of the time. So look for a prior urinary tract infection. Look for like hydronephrosis. Look for an infant who was like maybe a preemie and had an umbilical artery catheter and maybe a thrombosis from that. Usually there aren't any symptoms with hypertension, and it's usually taken up on routine exam, again, repeated measures. Diagnostic tests, repeat the taking the blood pressure with the right size cuff over the next couple of weeks. Rule out coarctation, so take blood pressures on all extremities. All children with secondary hypertension, and usually it's age-related, you should have a renal evaluation. This child had a BUN of 24, creatinine of 1.8. That's a little high for a 5-year-old. You should be imaging the kidneys. Get an ultrasound. Make sure there's not hydronephrosis. Okay? And you should do an echo to assess ventricular size and function. And the therapy of hypertension in children is the same as in adults. You're going to use diet, exercise, salt intake, things like that. And you're going to use medications like diuretics, angiotensin-converting enzyme inhibitors, calcium channel blockers, and beta blockers. Okay?